Ferri as our, I guess we call it visiting professor for these ground rounds. Surgical ground rounds are actually mission rounds. Again, these are relatively new rounds that we started in the fall. So every month we have someone from the department or someone from outside to give a talk that we think has important lessons for the whole surgical community. And I'm quite happy that Dr. Ferri actually volunteered to present this talk. I could actually spend a long time actually going over his CV and presentation to you, but just briefly, Dr. Ferri is the David S. Mulder Chair in Surgery. He's an outstanding clinical scientist, clinical surgeon. He's a professor of surgery, both in the department and also in oncology. He's made a number of very primary contributions to the understanding of esophageal cancer and into an inflammation and the relationship between inflammation and cancer. He has not only an active scientific group, but he also has a very active division as well. And they're really expanding. I think thoracic surgery, if left unkept, will actually take over the department. And I guess, Lorenzo, that's part of your mission, is to explain to us what you're doing in your division and how you've been able to create such a great model for the rest of the department. So, Lorenzo, it gives me great pleasure, and I'll give you the I guess the Zoom, and anxious to hear what you have to say.
Awesome. Well, thank you so much, Kevin. Thanks, and thanks, Liane, for inviting me for volunteering me to give this talk. But it's an absolute pleasure to always talk about the division. I'm really proud of the group of surgeons that we've compiled and the multidisciplinary members of this group that have really allowed us to flourish even in difficult times of budgetary cuts before COVID, and trying to instill sort of are the lessons that we've had, try to impart on them for our younger generation to see how we can still build, how you can build with a purpose, but you also can cut with a purpose. And sort of show us what we've done over the past, I guess, 12, 15 years. So the title of my talk is the McGill Division of Thoracic Surgery, Evolution and Growth in an Unpredictable Era. So overview, I'm just going to give you a little bit of a historical context. We'll talk about the process of centralization, which has been sort of the key notion that has been the foundation of my tenure as divisional director. I'll show how that has had an impact on clinical volumes, and I don't want to say we have cannibalization, that's not the right term, but how we try to do is bring increased clinical volumes to the MOHC, and how we've tried to work within limited resources, even in the MOHC and McGill. I'll show how how technological innovations within our division have helped us do that, how this has influenced research, and ultimately training and education. So sort of the full three-legged stool that Ray Chu taught us about as the tenets of academic surgery. So to start off, we have McGill Thoracic Surgery has a long legacy in operations of the chest. This is Edward Archiebald. Love the hat, which I think I still have one of those somewhere. Actually, I still have his gown that Prasanto Chowdhury found before they threw it out at the Royal Victoria Hospital when they moved. Edward Archiebald was a true pioneer in thoracic surgery. He performed the first anatomical lung resection for cancer in the world, where there was separate ligation of the hilar structures. I'm not sure if everyone has seen the Crown. My wife's making me watch the Crown right now during COVID, and actually the first episode of the first season, there's a pneumonectomy, a pretty accurate pneumonectomy on scene of the king. But that was possible because of what Edward Archibald did at the Royal Victoria Hospital in 1933, right around the same time that Everett Scram had done similar with mass ligation. But this is the first anatomical lung resection for cancer everywhere in the world. And you can see these are the Royal Victoria Hospital ORs. They did not change at all until they moved down to the Glen. Then Dagmonroe at the chest was a true pioneer again in not only lung cancer surgery, but also he performed the first lung transplantation in Canada. This is one of his, I guess, hybrid cows with, I guess, a transplanted lung in 1965. And this really fostered, this sort of ushered in the era of lung transplantation that the Toronto team has really taken off with. This is the then there's McGill was really at the forefront of surgical management of tuberculosis. You can see here Fraser Gerd at Montreal General Hospital and Norman Bethune, both pioneers in surgery for tuberculosis. You can see some incredible collapse therapy treatments, initially with thoracoplasty, where we drop down the lung for patients with tuberculosis. Subsequently, with this I love this concept with lucite balls, this plombage, where we insert lucite balls into the chest in order to, basically ping pong balls, in order to cause collapse therapy. So these two are luminaries. We're really at the forefront of surgical management of tuberculosis. So that was sort of what McGill Thoracic Surgery was in the 20s, 30s, 40s, and 50s, and 60s. And thoracic surgery was done in pretty much all the McGill hospitals, the Royal Victoria Hospital, the Chest, or King Edward, St. Mary's, Jewish General Hospital, Montreal General Hospital. It was done in pretty much every one of these institutions, and it had a strong position at each one of these institutions. Then cardiac came along. And cardiac basically took over everything, took over all the resources, took over all the interest, and really pushed thoracic surgery to the side in each one of these institutions. So what ended up happening is that in the 70s, 80s, and 90s, thoracic surgery had, although people were trained in both cardiovascular and thoracic surgery was sort of as a loose appendage. It was pushed off to the side. It's sort of like the invention of the third wheel. So thoracic surgery at each of these institutions really became an appendage attached to other services. So when I came on, around the same time that I came on, we had surgeons within the McGill realm at the MGH, RVH, Jewish General Hospital, and St. Mary's, all performing thoracic surgery. Within the MGH, up until 2004, it was a combined division. Dr. Mulder was the head of the division of thoracic and cardiovascular surgery. It was a combined unit within cardiac surgery. We had 6 beds out of the 25 beds on 11 East, and we're sort of pushed off to the side in a closet, basically, if you will. So Christiane came in 2003, I came in 2005, but we were still sort of an appendage of cardiac surgery until it moved in 2008 to the Royal Victoria Hospital. At the RVH at around the same time, before this, Jean Morin stopped doing cardiac surgery, and he was still doing thoracic surgery. At the Jewish General Hospital, the incredible Nate Shaner of unlimited energy had stopped doing cardiac surgery a decade beforehand, was still doing vascular and thoracic surgery, but was really an appendage of the vascular surgery division, although he had a very active thoracic surgical practice within that division. And St. Mary's, Dr. Chugtai was performing lung surgery resections in the middle of a practice of general surgery. So we're all sort of became an appendage of each of these institutions. Which there was no sort of concerted effort in order to build into one combined unit at that time point. But we recognized that this in mid 2000s that we really need to centralize and try to improve, not only improve outcomes, but also to centralize all at least within McGill, the thoracic surgical services. In order to really create an expertise. Although every one of these surgeons are outstanding surgeons in their own right, by being in separate places, they don't build off each other. So I think the additive group, if we had Dr. Shaner, Dr. Mulder, Chugtai, Morin, all in one same hospital, the added benefit would really be exponential to the patients. So there's a process of centralization that started in the early mid 2000s and continues up until even this date. There are 3 main factors that drove or forces that drove the centralization. First, it was by default. And so the chest closed down, therefore the chest was merged into the Royal Victoria Hospital, that's surgery division. Surgeons started retiring. Shaner at the Jewish, Chugtai at the St. Mary's. They started sending patients over to the Montreal General Hospital. When Jean Morin retired, the patients started referring. So that was sort of by default. Up until 10 years ago, there were probably 30 different hospitals throughout the province who were still doing esophagectomies. Excuse me, some of them with mortality rates 50%. I'm not joking, 50% mortality rates. And so what ended up happening by default, those surgeons started giving them up because they recognized that the billings, the meager billings that you're getting, the amount for these cases just wasn't worth the incredible pain of managing these patients, and the outcomes were quite poor. So that was just by default. Patients, surgeons just started giving up certain operations. Beforehand, they would keep them within their center. Now there wasn't a much of an incentive to hold on to them. Unlike the United States, where there's an incredible incentive for each individual hospital to hold on to cases. We didn't have that issue here. So esophagectomy just by default started moving towards one center, and lung surgery by retirement of certain key surgeons, incredibly profound and excellent surgeons. Just by their retirement, that by default that started bringing things over towards the Montreal General Hospital and centralization in one center. Then came the decree. So right before I started as divisional director, Dr. Mulder was involved in a ministerial initiative to centralize thoracic surgical oncology to a high volume center. This was promoted initially by Antoine Lutfi when he was head of the Direction contre le Cancer. And this was a four-person panel that met. They reviewed all the literature, and they came with a recommendation that thoracic surgical oncology should be centralized into certain centers. Initially, they had 12 centers, which was way too many. But at least that initial plan was put in place, that it made sense to centralize. So that was in 2000. I came on as divisional director in 2012. And then that process started to develop. Just like anything that comes from the government, usually takes 10 to 15 years to plan. And then every time there's a new government, the plan changes. But irrespective, this is one that took a while, but actually started to move hunker along. So by 2013, due to a combination of both default centralization and decree centralization, there was the thoracic surgical services for the McGill Ruiz, 1.9, almost 2 million people, was largely centralized to one center at the Montreal General Hospital for the entire Ruiz. This was finally after a lot of very short timeline dictums from the ministry. We had to meet with every single hospital, DPS and the board, and develop ententes with each individual hospital. So we basically got 6 weeks to do all that, or for those before they had to shut down. So we had to meet with Verdun. I went to the Verdun boardroom maybe 7 times over this period of time because they were trying to send their patients over to the CHUM. That's where they trained. We were able to convince them to maintain within our Ruiz and send our patients within our Ruiz. So in 2015, centralization became basically complete. And so the division of thoracic, all thoracic surgical services for the entire McGill Ruiz was centralized at the Montreal General Hospital at one site within McGill. And this is basically a Ruiz-based division of thoracic surgery. So we currently cover the 20-odd hospitals, and we're the sole surgical thoracic surgical backup for those 20-odd hospitals. So we're managing chest tubes at those 20 different hospitals. We are managing empyemas at those 20 different hospitals. So call can be quite challenging. So we are the only backstop for the entire Ruiz in the division for thoracic surgery services. So the third factor or the third force that was driving, am I still on, or is that someone else? Someone else coming in there? No, I'm still on. Can someone mute whoever's beeping there? So the third factor that was driving centralization was, and the most recent one is the reputation. So after we had, although we are the sole surgical service for the division for the the entire Ruiz with relation to thoracic surgery. Over the past year, the reputation of the strong care that we provided at McGill has gotten out. Over the past year, we've now have referrals based on, some of them are actually ententes, and others are just by reputation for providing strong care by the members of this division. So now we have we basically cover a much larger area. So in 2000, if we looked at the referrals for 2019, 2020 that came in, we have over 40 referring hospitals from across Quebec, every different region. We're for esophagus, we truly are a provincial program from Rimouski to Quebec City. We have a actual formal entente with the University of Sherbrooke. So the Ruiz Sherbrooke, we perform all their esophageal surgery. And so what we've tried to do is really centralize this into one area to really improve outcomes for the patients and have sort of a common mindsets on how to manage the thoracic oncology patients. Now we don't do all the care here, so we just do we do surgical planning. We do the treatment planning here. So we often see the patients initially at the time of diagnosis. They go back to the referring institutions for oncology care. So if it's chemoradiation therapy or chemotherapy or whatever they require, they go back to their home institutions, and then they come back to the module to McGill for the final surgical treatment. So this is taken a lot of energy and effort. Of navigation, of sending patients back and forth, and how do we communicate that all at the same time when our institution is going through incredibly painful restructuring of administrative support staff. So that made it quite challenging, and so we had to find innovative ways in order to make sure that there's a bi-directional communication between the Montreal General Hospital Division of Thoracic Surgery and all these institutions outside. So only around 20% of our patients actually come from within the MUHC, and over 70% of our patients come from outside of McGill. And so we're working through each one of these hospitals back and forth by direction. That requires a lot of coordination. So what has this led? This led to a significant increases in thoracic surgical volumes. You can look at from when I first came on in 2005, you can see we hit around 130, 140 lung resections. We're now up to threefold increased, around 140 to 150. You can see the slight dip during the year of COVID, during that period of time, as we all expected. However, in the same time for esophagectomies, we see a 4.5 fold increase in the number of cases from when we first started through the centralization process, first by default, then by decree, then finally by reputation, and gastrectomy with an entirely new program where we're doing approximately 50 a year. This represents the highest volume program in Canada and one of the highest in North America particularly for esophagectomy and gastrectomy. There are very few centers who do both in the same division, but it does provide a very good continuity of care for across the diaphragm for these malignancies. So this increased surgical activity is really driven by 8 dedicated surgeons. Dr. Mulder is our guiding light, the one who's really inspired us and really started our division. The 3 of us worked alone for around 10 to almost 15, 10 years by ourselves. Then we were fortunate enough to have a combination of those increased referrals and increased surgical volume with the recognition by the ministry that we probably need more than we initially had only 2 spots for thoracic surgery, which was less than a hospital like San Jerome. So luckily we were able to get more positions, and we were able to recruit initially John Spicer in 2005. Then we have Cools, Matt Rousseau, and Carmen, who we share with Sacré-Cœur and General Surgery respectively, and most recently Sarah Najmi, who came just this year after spending 3 years in Duke. So we're lucky. We went from what Dr. Weimer, when I was a resident on Dr. Mulder's service, he was by himself. working nonstop on call, operating 2 to 3 days a week. Only person who would cover him every now and then would Ray Chu when Dr. Mulders was stuck somewhere or traveling with the Canadians. And so we've come a long way since the time when the early 2000s, when Dr. Mulders was basically by himself. So we found in order to have to do that massive increased volume, we recognized that the institution and the government were not going to give us significantly more increased resources. We really had to find ways to improve outcomes and increase efficiencies in thoracic surgery, and doing more with less beds. The part of that, like every single surgical specialty, has really been the increase in minimally invasive surgery. For when we first started, we did all open lung surgery and all open esophagectomies. At present, due to the excellent work of our staff, the Spicer, Cools, Sarah, Matt, and Carmen, we've really increased our minimally invasive surgery footprint, and now represent one of the highest rates of minimally invasive surgery in Canada, both for vasolobectomies, where over 70% of them are done by minimally invasive surgery, and esophagectomy. I've been really being pushed hard by both Carmen Mueller and John Cools to increase our MIS rate. Even 2 years ago, this is only 30%. So now we're up to 70% of our cases being minimally invasive surgery. What this means is that people get out quicker. So we have fewer beds. We need to use those beds as much as we can and try to get those patients through our hospital system in a safe manner, but with quicker recovery. So we were an early adopter. We combined this increase in minimally invasive surgery with becoming an early adopter of enhanced recovery, and we've really drank the Kool-Aid that Liane Feldman and Frank Carley prescribed. I remember vividly when I was a junior resident at the Vic, and Frank Carley was trying to send people home post-op day one in the mid '90s after colon resection. Working with, I can't remember his name, and it was the colorectal surgeon at that institution. So we were one of the first adopters. When I was a fellow working with Jerry Freed and Liane, we had the first pathway for benign hiatal surgery. We're trying to get them home on day one. Then maybe 7 years ago, we realized that the beds were lacking, so we started sending them home in day surgery. So now we published our results. We have around 80% of our patients go home on the same day of surgery, even for a complex resection such as parasalpingo hernias or epiphrenic diverticulum that I did yesterday. Vasolobectomies, as I said, there's around 70% of our patients. If you look at the STS database as well as the Quebec data, the average length of stay is around 5 days. The STS, or Society of Thoracic Surgery database, it's 4 days. Our median length of stay after vasolobectomy is 2 days. This is industry leading. And thanks to the incredible pioneering work of John Spicer, we're really trying to push this envelope and trying to find a way to get these as day surgery. We found that 25 patients are leaving on post-op day one after vasolobectomy. Again, this is unheard of in the rest of the country, and we're starting Dr. Spicer starting a day surgery feasibility study for vasolobectomies. For esophagectomy, despite the fact that we do a very large number, around 80 esophagectomies a year, again, this is the largest program in Canada by far. Our length of stay is still the lowest, the decile in the NISCRIP database, where the median length of stay is 10 days. We're able to get that down to 7 days. Again, this is by far the lowest in Canada. So this requires a lot of this type of maintaining these type of outcomes and making sure patients are safely ushered through the hospital with those limited beds that we have really requires a lot of communication and cohesiveness within the team. So again, this is our nurses on the ward who are outstanding. This has always been a very strong team of nurses, even from the days when Lynn Morgan ran the cardiac and thoracic ward. The nurses have always had an integral part and driving the outcomes of these patients. Very, very, very involved. I remember Lynn Morgan used to round every day with us as residents, and she ran that unit like I'm not sure what, like a general, if you will. So we have, in order to increase our communication cohesiveness to make sure patients are ushered through the system, we have daily morning team rounds where all surgeons meet at 7 o'clock with the residents and our nurses at 7 o'clock in the morning, and we go over a plan for every single patient. We try to predict and identify problem areas that may arise for the day, either in the OR or outside the OR. That has been extremely instrumental in, we've done that for the past 2 years, and it's really instrumental in making sure that the patients are ushered to the system, so there's no blocks, and there's no, everyone understands exactly what's happening on every patient. It is vital. We can't just be physicians. It absolutely has to have the nursing staff here. Here's Marcia, our assistant nurse manager. This is Ludovic, patient care coordinator, who's now studying to become a nurse practitioner. We also have, in addition to this, every week on Friday, we have weekly planning rounds for the following week. This is where we try to identify gaps in the OR that may arise. We go through every patient who's going to have an operation, and we identify where we can fit patients who are in the hospital waiting for an emergency case. So we really try to spend a lot of time trying to fit trying to find out where patients can best go through this whole system. So what's interesting is that COVID has also dampened the amount of time we spent together in the same room, but it actually has increased the attendance to these rounds. So pretty much every morning we have, I would say, 7 or 6 out of the 8 surgeons on call, either in person or or on call at these rounds every single day. It was like going back to residency, where you have to be in hospital at 7 o'clock every morning. It was and we did it, but now by phone, it actually has increased the attendance and the quorum that we have at these meetings. It really keeps us on the same page, and it really keeps us focused on patient care, and make sure we have bi-directional communication between the nursing staff, the allied health, our nutritionist comes to this, a social worker comes to these meetings as well. Make sure every single week we have smooth care through the patient trajectory, and make sure patients get out on time and when they're ready. Obviously, none of this can be done without the support of the clerical and administrative support. Again, we've had to restructure a lot of this. Has been extremely painful. We were down to 1 person when we had the reorganization. Everyone in the hospital went. I all shared your pain. So we've had to rebuild that. A lot of it came from our own institutional funds. A lot of the navigation, where we go between our hospital and the other hospital, the communication, that we required, we had to find philanthropy to fill those positions in order to be able to have that bi-directional communication. Now, I'm really grateful to the hospital and the ministry to recognizing that, and the ministry have just recently given us funds to increase our resources as far as navigation is concerned. So all these people are instrumental in making sure that the patients flow through the system appropriately, safely, and in a manner which is satisfactory to them. I remember one of my good friends, Wayne Hofstetter at MD Anderson, said that that volume is king. So basically, if you have the surgical volume, everything else follows. If you have the volume of patients, your education increases, your research increases, and clearly your clinical practice and your impact on clinical practice increases. And that's really what's happened. I mean, with our volume, we're recognized in one of the highest volume centers in our academic centers in North America. This has has attracted incredibly bright surgeons from around the world to come to spend an extra year or 2 years with us in a new fellowship in thoracic and upper GI surgery. Although we've had fellows all along, starting in 2010, really it started when Spicer became program director. And we have a formalized fellowship where we take now approximately 3 to 4 fellows a year, 2 clinical and 1 to 2 in research, really from around the world. And all these people are going back to academic centers and really bringing up. They bring a lot to us as far as international experience and techniques. They spent 2 years with us, and many of you met them. They're really are outstanding individuals. This really has really taken off over the past 5 years. As you can see, we have both Palestinians and Israelis. They all get along in the same area, and we've made it. We've really learned a ton from our fellowship. I think that's really kept us cohesive as well. What else has kept us cohesive is the stipend professorship. This is something that we do in partnership with the adult cardiac and congenital cardiac divisions. 50 years ago, it was all one combined division. So Shirley Stikeman and her family started this visiting professorship in over 50 years ago, after her husband had died from a malignant mesothelioma operated on by Dagmonroe. And it is really the goal of the professorship was really to sharpen the minds of people here and people elsewhere. So we bring the world experts in thoracic, cardiovascular, and congenital to McGill, and they're again a bi-directional exchange of ideas and fellows. We had 50 years of this just recently. This is the oldest visiting professorship, not only in the Department of Surgery, but the oldest continuous visiting professorship in all of McGill. Dr. Mulder had just published his book, the second visiting professorship and enduring McGill legacy, just this past year. And you can see it's really is a who's who in the field of cardiac and thoracic surgery. Some of them are old friends, Garrett Walsh, so forth. But this is really this has really been the glue of the divisions, and it's an area where it's not only an opportunity to celebrate graduating residents and the scientific achievements of both the residents and the staffs, but also what I really, really appreciate about this is it's a reunion. It's a reunion of not only people who trained here, but also people who have been inspired by this division, who were in other service divisions such as general surgery, and went on to become thoracic or cardiac surgeons. And here you can see this is our 50th anniversary here with Alec Patterson. And you can see we have many of you will recognize this crowd of surgeons. There's Wael Hanna. I know you can see there's Garrett Walsh. And you can see the people coming back to McGill every year, and it really creates it fosters a phenomenal environment for training and ideas, and it really keeps us together. Research really has been the foundation over the past 15 years, and has a central position in the Division of Thoracic Surgery. So whereas all members of our division actively performs and undertakes clinical research and trials, we have been incredibly fortunate to have 6 outstanding women in our clinical research staff that really helps us maintain extensive databases and tracks down data for us across a province, really. But what I think has really been what has fueled, as we talked about how volume is king earlier, is that our clinical volumes fuels our research, and our research fuels our clinical volumes. That's where I really think it's important that thoracic surgeons not only be engaged in surgery, but also be engaged in the entire trajectory of whatever disease process that you're treating. And that's something where we've done a lot of trials that are centered on oncology, on chemotherapy trials that are centered within the Division of Thoracic Surgery. Although I started this, where I found this really helpful is that when I first came back, I started an investigator-initiated trial on chemotherapy for patients undergoing surgery for esophageal cancer. This put us on the map and brought us an incredible amount of patients and built our a reputation as an academic center for esophageal cancer, and that we've seen the results of that. The person who's really taking the helm of that is John Spicer right now. He's really driving the bus here at McGill on immunotherapy trials for lung cancer. Was an outstanding trial that is due to be published relatively soon. It's a closed accrual, and it's a neoadjuvant immunotherapy for lung cancer. And Spicer, even though he's only been here for 5 years, he's had the highest accrual in the world for this trial. And this has led into further trials looking at investigator-initiated trials in immunotherapy and chemoimmunotherapy. Although we have great partners in oncology, we found that it's really important for the surgeon to be driving the bus in these trials where surgery is part of where the patient ultimately will have surgery. So that is, again, that fuels our clinical practice, and our clinical practice fuels our research, and the two go back and forth, and they're instrumental. As you've all have seen, I really apologize. Over the past 25 years, you've all seen neutrophils rolling across the screen in every Fraser GERD meeting, but we've still continued that vein of fundamental and translational research. To that, though we have the three surgeons here who perform bench work, We were really fortunate. I think things really started to take off when we hired two outstanding scientists, Vina Sangwang, a cell biologist, cancer cell biologist, and Sven Bailey, a computational biologist who specializes in the epigenomic drivers of cancer. Well, that really helped us put forward. Our research staff increased significantly. We currently have 6 technicians and associates. And so going back from when I first hired in 2005, when we had 1 research staff, Betty, followed by John Spicer a year later, we now have around 25 to 30 research staff and students and staff within this in fundamental and translational research. So that's a lot of people. This is pre-COVID, our last Christmas party. The next one's going to be a lot more boring. But in order to do this, we recognize that we have, although we have similar research areas, we all need a little bit of space individually. And so we have the research, the bench and translational research in two different locations. The lab at the Royal Victoria Hospital moved to the Glen. It's based in the cancer research program where we focus primarily on cancer metastasis and immune cancer crosstalk. Spicer and John Cools have really taken the helm and they're running with this. And they're doing outstanding work down at the Glen. I still maintain a footprint there as well. However, as we move towards more translational, I moved personally towards more translational research, and as has our group, we need to construct a lab that was adjacent to the operating rooms where we can process tissue very rapidly. And though we have a relatively new facility for us at the MGH where we do translational research, and we center on live banking and organ chip program. And we're looking primarily at chemoresistance for a bunch of thoracic malignancies. And the real tenets, the strength behind this is how the close proximity to the operating theaters, where we can take live tissue and process it within minutes to do either single cell sequencing where every second counts. We can process this tissue within minutes and start sequencing within around an hour. That is unique, at least in our fields. More importantly, we can take live cells from the tumor, immune cells, epithelial organoids, or patient-derived xenografts. We can take endothelial cells, fibroblasts, and we can. In that lab, we're looking at how certain drugs why some patients respond extremely well and other patients don't respond at all. You can see this organoid responds extremely well to chemotherapy and was completely destroyed. This one still sticks around. So what's the difference between these two that's driving this? Finally, we can take all these cells and we can seed them into an esophagus or organ chip, and really look at how drugs respond in the most physiological relevant ex vivo human model that we can have for cancer, has really developed the esophagus chip. And we're really lucky to have incredible collaborations around the world to help us build this translational research lab. So obviously this requires a lot of money. By working together, the five PIs, we all bring something different. We're all on pretty much all of our grants. We all circulate who's a PI and who's the co-PI. We all bring in different angles, and by doing that, we've been extremely successful. We've funded from all the major societies, research societies, for peer review funding. But still, this is not enough. As everyone who does mentor work knows, the amount of money we get from CIHRs covers half or a quarter of what you need to do. So we've really been dependent on philanthropy. So we're extremely fortunate to have incredible support from philanthropy, which has been indispensable for both our research, but also for our clinical growth. All the navigation that we've done between our site and all those 40 odd hospitals around the province, that all started, we've been doing that for the past 7 years. That all started from a donation from the Jaroslawski Foundation, allowing us to hire 3 people in order to do all this back and forth group. So these are our main donors. With those funds, we run our research lab, we run our clinical outcomes lab, and we've been able to fund an additional 2 endowed chairs, which we'll start interviewing for very soon into our division. We found those indispensable to have those scientists collaborate within our group. So if we look back, we really have come a long way. take away from the incredibly pioneering work from Archiebald and Bethune and Fraser Gerd and so forth. We really have come an extremely long way, and we hope to be able to continue this in the future. I'm really fortunate to we've been able to recruit under the shadow of Dr. Mulder and a really dynamic group of surgeons and scientists, and we hope to be able to continue this for the next generation. Thank you very much.
Lorenzo, thank you very much. I guess all I can say is, wow. Congratulations to you and the team. Fantastic work, and I guess excellence at every area. I do have a question, but maybe I'll just go through the chat if you let me, and see some of the questions that are there. We have one from Dr. Urgina. I'm not sure it's a question more than a comment, but he says, Lorenzo, perhaps multidisciplinary approach changed the prognosis and treatment of chest cancers and influenced the resurgence of thoracic surgery. So I guess it's a question of resurgence of thoracic surgery, because I suppose TB and to some degree as well, the post-Spanish flu empyema treatment ushered in thoracic surgery. And I guess that's part of his question is the resurgence of thoracic surgery, and that cardiac had developed because there was a lot of innovation in that area. So maybe just your comment on that, and then we'll get.
I agree 100%. I mean, you became a cardiac surgeon for a reason. It was a lot of excitement in the 80s and 90s, and thoracic surgery was sort of pushed up to the side because there really wasn't much development. What really made it interesting, where a lot of patients are now re-entering into the surgical arena, is because of our advances in oncology. And that's really why I think it's important for us as surgeons to be involved in those chemotherapy agents. That's why John Spicer's role in immunotherapy for lung cancer is so vital. That's why what really our practice did really took off when we became oncologists who do surgery rather than surgeons who dabble in oncology. And that's where the advances are. So those patients we used to didn't operate on them because there's no use to it. You do a esophagectomy, 3 months later they're dead from metastasis. That changed completely. I remember that. I remember when I was in Hong Kong, we did an esophagectomy, patient had a complication, and then before he could go home, he recurred already, which is so frustrating. And the oncology, the chemotherapy changed that. So our understanding, becoming oncologists made us better surgeons, because we know that the patients, that increased our volumes, increased our outcomes, because we were operating on patients who had a better chance of surviving.
Question from Greg Berry. Can our admin use the impressive and substantial increase in volumes to request more resources to care for these patients?
Oh yeah, that's yeah. So if you all remember the CAPS process, we all did that. That was my first introduction to divisional directorship, is doing that piece of that. Anyways, that wonderfully useful process. So that was the whole idea was to identify areas that we want to concentrate on. Yes, we can. You can apply to the ministry. We have done that innumerable times. I have given this similar talk to everyone at every level of government, all the way up to the top. And you know what they always say? You're given an envelope, and you guys deal with the envelope you're given. We have been, with one notable exception, just because we were just a small amount of funds came from the ministry for navigation after us fighting over and over and over again, because we were paying that out philanthropy, and just now that's coming to fruition. That's the only thing that we've been able to get from the government. But I have spoken to 4 CEOs and interims about this. And I'm sure they've all done their job trying to petition the government, but that's quite an arduous task.
Yeah. Well, I guess when you increase, activity, resources have to come from somewhere. So, so from Prosanto, Lorenzo, congratulations. Could you comment on how to get the institution to recognize the areas that require same kind of structured approach program building, especially with the view to explicit in ruins entente? I'm not quite sure what that means at the end there, but.
Yeah. yeah,
Ruins ententes, yeah. Ruins, I guess.
Boston Bruins. I guess.
Yeah, that's right. Everything's in ruins. Go ahead.
No, all I can say is I've had to give this version of it, literally this version of talk, maybe 50 times, and the number of times and the problem is as we all know that governments change, the hospital administration changes, circulate. There tends to be used to be a lot of turnover, so you would have to have the same discussion, the same nurse manager, because those nurse managers change every 2 years. So it was extremely painful process, but we had to be persistent. That's the only thing I can say. Just keep on being persistent. What really helped is by building the bridges to the other institutions. So a lot of it was pounding the pavement. There we go. To go to the other institutions and develop those either formal or informal ententes with other hospitals. So the patients come here. Once you have the patients come here, particularly if they're then it's once you become dependent, once the other hospitals become dependent on you, then the ministry tends to notice that they become dependent on you. So they have to do something, or the ministry and the administration has to do something because they're here. They have no place else to go. So when we became the only site of the thoracic surgery in the Ruiz, there was no place for those patients to go. They have to come here. They can't go anywhere else. They can't. There's no other. There's no place for them to go at all. So the administration finally recognized that.
Great. Comment from Dr. Regina. Maybe you need a godfather like Dr. Mulder. And congratulations from Talat Chaktai. Amazing work, great presentation. Enjoyed listening from Doha in Qatar. So you got a world view here, Lorenzo.
Awesome.
I do have just one brief question. You have amazing fellowship. Don't have a residency training program. Can you comment on that, or is that by design, or?
Yeah. Yeah, that's by design right now. We've talked about it every year to do that. To the amount of work that's required for one you guys know this. The amount of work that's required for one resident a year it's enormous through the Royal College. So we have talked about that. Now that we have more people, maybe I can convince one of my younger new recruits to take that on as at the helm. But that's a good point. We talked about it every now and then whether or not it'd be worthwhile to proceed with that. We've been reluctant in the past to do that and preferred just to hire established surgeons who are coming here for academic focus.
I would think that for the Canadian community, it would be important that your group have a residency training program.
Yeah, I would say that we do get a lot of electives from other programs, Ottawa, Toronto, Manitoba. We've had people, quite a few, come through for 2 to 4 months for focused areas of that they want to examine or they want to get. I mean, obviously, our esophagus exposure is around 4 times the rate of most centers, so they like to come for that particularly. But you're right. I think that we've been talking about this for quite some time.
Great, Lorenzo. I don't see any other questions on the chat. I don't know if I don't want to put Dr. Feldman on the spot. I don't know if she would like to comment.
Thank you. I think, Lorenzo, that was really an outstanding talk. I think very inspiring. And it shows I think you've taken advantage of, in a very positive way, of some aspects of reorganization at the systemic level, but you've really run with it. And so it's that there are structural opportunities, and they may be presented in a certain way or not, but it's also what you do with those opportunities. And you've created outstanding, internationally recognized program, building on, obviously, building on the traditions that were there, but you've taken it to a completely other level. And I think the other thing that I think you've done really, really well is that you've taken advantage of making total use of the resources that we do have. So, like you said, completely embracing enhanced recovery When I give talks on enhanced recovery, people laugh because our first enhanced recovery after surgery pathway was esophagectomy, one of the most complex procedures that we do, as opposed to other places where it's always about like right colon resection or something fairly standard. Esophagectomy, people actually, they're like, what? And that's because of Lorenzo's and his group's, enthusiasm and ability to embrace these changes, and including minimally invasive surgery. I think that's Jerry's legacy, and it was clearly his intention to recruit people that had that training, and no matter what their subspecialty ended up being. I also think in terms of the number of faculty that you've trained. The people doing translational and bench research are people that you trained and then went to fellowship and came back, who have then been able to get external funding on their own, which is a fine balance to maintain, and they've been successful. And through that pathway, then when people get external funding like FRQS, you're able, even without an additional PEM, to continue to recruit. So I think that that's another aspect of building on the opportunities that we have. And I also think that you've done really well at building those bridges with all the hospitals, and including, you didn't mention this, but going out to Gatineau, even yourself and all of your group going out there physically to run clinics there, despite I think that's been also extremely helpful. So I think this is a wonderful talk, and a great example of the work you've done, but building on the traditions that we have and creating something that's extremely sustained. The people that you've trained and the program that you've built, I think absolutely outstanding. So thank you very much for putting this together for us this morning.
I'll say that one. Thank you very much, Liane, for that. I'd like to say that really all this is built on a foundation. This is nothing new. Dr. Mulder really instilled in us the importance of having a cohesive group. There's no hierarchy. Everyone makes exactly the same amount of money, whether or not you do all research or do all clinical or you have other things. Everyone, that equality makes it easy when we're not squabbling about OR's time or schedule or case, where cases are common. We help you. If I can't do something that someone else does a case, it's by having that environment allows each surgeon to build their own areas without repercussions, financial or reputation wise. We all try to work a team, and that's really Dr. Mulder who really instilled that in us. And so I think this is basically a model of what we do now is basically a model of Dr. Mulder. I mean, he himself could do all what we're doing. All 8 of us could do when he was younger. Now we have to find this 8 of us who try to recreate what Dr. Mulder was in his youth.
I don't see anything else on the chat, so I would like to thank everybody for your attendance, and we had great attendance around, I think at the top, nearly 70 people, so that would certainly give a good viewing in the Osler. So congratulations, Lorenzo. Thank you very much. Next month, we have Dr. Jerry Freed, ex-department chair, who will be giving us, I'm sure, a great talk. So hopefully everybody will show up again. I think Dr. Freed has the same background as you, Dr. Feldman, right now.
The Osler Library. No, I think his is bottles of scotch. This is Osler's collection.
All right. Okay, thank you very much, everybody, and have a good day. Have a good OR.